Welcome to the webinar, Clear Aligner Therapy Protocols, Procedures, and Practice Applications. This lecture is being presented by our very own Brenda Kirkin, CDA, RDA, and will begin shortly. And now it is my honor to introduce Brenda Kirkin, CDA, RDA. She is an NDX iOS specialist covering the Midwest region, but really nationally sometimes. Brenda has served in dentistry for more than 25 years and is a certified dental assistant and a registered dental assistant, and has served as an adjunct instructor at the University of Detroit Mercy School of Dentistry. Brenda has extensively trained in such areas as impression techniques, iOS and PVS, retraction cord placement, provisionals, and photography. And with that, I get to say, take it away, Brenda.
Well, thank you. Thank you for everyone for joining me tonight. And just wanted to give you my disclosure. I or none of my immediate family members have any financial interest in any of the products that I am going to be talking about. I am a full-time employee of NDX, National Dentex. And Jessica went over a lot of my career, but I also taught throughout Canada and US on clear aligner therapy. And just want to let you know, at the end of this course, you should be able to evaluate and diagnose malocclusion and bite relationships. Get those accurate records and scans so you can export them for whatever liner company that you are working with, and compile all necessary information to make you have a successful case for your aligners. Also, identify the armamentarium used in attachment placement and IPR, which is interproximal reduction. And I'll talk about that when we get to that area of the presentation. And you'll be able to perform attachment placement and the IPR procedures. Just wanted to let you know that I am not a dentist, so I can talk a little bit about malocclusion. However, I do not diagnose, if that helps out at all. So I'm going to take you as if you have a patient in the chair. First thing you're going to want to do is diagnose your different classification of your malocclusion. And this is more of a beginner's course. I want all of you to have successful case and happy patients, right? So you want to do those easier cases, more class 1, either with a division 1 or division 2. Division 1 is protrusive, so there 2 or more teeth flare out. Retrusive is where 2 or more come more in. I say almost like, I don't want to say like a rodent, but kind of like that. So class 1 molar relationship is where your maxillary first molar buccal cusp meets with the fossa of the lower first molar. Class 2 is where the distal of your first molar cusp is in the center of the fossa. And class 3 is where it is way mesial of that first molar. And the famous person that we all know that has the class 3 is who? Jay Leno, right? So once you have your classifications to begin with, you're going to want to pretty much stick with your class 1 occlusions. Class 2 is more of your moderate cases, and you want to keep like with your crowding. You want for your mild cases to start off with is 0 to 4 millimeters, moderate is 4 to 6, and then more complex. You don't want to start your aligner therapies on your patients, like I said, with the complex. And when we're going to talk about crowding and aligners, you want like arches. So if you have a lot of spacing on your maxillary arch and crowding on your lower, unless it has a tooth discrepancy, and you're going to set that up for like crowns or even veneers, that's okay. But if you're going to try to get them without any restorative, you want like arches. So mild to moderate crowding on upper and lower, spacing the same thing on the upper and lower, and like same thing with your overbite or overjet. You want it in the mild to moderate area. And for your midline displacement, if it's like Tom Cruise where his tooth was center, you can still do that, but like I said, to begin with, we want mild to moderate. And the same thing with a deep bite, open bite. You can have mild cross bite. Any questions so far?
We do have one, but this might fall under your disclosure of not being a doctor, not being able to diagnose. So I'm going to predecess that before I read it.
Okay.
And an attendee stating that they are 78, no perio pockets, some horizontal bone loss, posterior black triangles. They're asking if
Okay.
they can use aligners to close the spaces between their teeth. The food traps are driving them crazy.
Yes, and unfortunately, as we age, myself included, that depending on your malocclusion, your teeth can distalize a little bit, correct? So if you are having food traps, yes, that would follow under like a mild case. Um, Sometimes you have to have a little bit of IPR along with that to close it up a little bit more. So the best thing to do is to take a scan and submit it, and they can tell you how your outcome will be. And, like a lot of aligner companies, depending which one you're using for a treatment plan, it's like little to no cost. And I'm going to talk a little bit about what kind of cases also and why you would want to do aligners. If they have like the malocclusion, look at their teeth, see if they have wear facets. It's really helpful for your patient with their abfractions, because misaligned teeth are wearing down and breaking down your teeth and chipping them. So, a clear aligner therapy, a lot of patients really love it. So good cases to start. This is courtesy of Dr. Mohammed Al-Jahosi. As you can see, there's before, and we have upper crowding, and this was an 8-month case and pretty good outcome. And what is good too also is if patients have bone loss, recession, if they're in malocclusion, that's just going to keep further doing damage, right? We want our patients to have wonderful bites, wonderful occlusion. And here is the same case of 8-month. You have the crowding, and it's very important to do proper photos, not only for whatever aligner company you use to see that, but any patients that you have that are going through any type of ortho, or I even say even a lot of restorative, you want good photos for your own records, and especially for ortho, because patients do forget how they started out, right? So a lot of times I do my beginning a couple months after they're in aligners. I take a new scan, take new photos, and I show my patients, so they get really excited because they don't realize how much their teeth have moved and improved. So it keeps them very motivated. And I've always found that it motivates them enough to wear their aligners for at least 22 hours like they're supposed to a day. But as you can see, I love where like number 10, as you can see how it's rotated and after 8 months, right there in line. And this is another case with Dr. Salam Quadri, and there's crowding on both upper and lower arches. They do have spacing between their first bicuspid and their canine. And as you can see, before and after. And here's another one of her cases, 5 months. As you can see before, there's lower anterior crossbite, and after that's gone. And sometimes if you have a case that this patient was happy with the results, but if you wanted to go a little bit further, you can always do a mid-course correction or refinement to change anything. And we'll get into that because we're going to have, stay tuned for another webinar, and we will go over like mid-course correction, and attachment removals and tracking issues. So if they have a tracking issue where their aligners are no longer fitting or the teeth are not going in track the way that they're supposed to. Good cases to start off before, and this is that patient that was in the crossbite, and you can see on the left side that crossbite is corrected. So then, before I get into the records needed for clear aligners, any questions on the malocclusion or which cases to start off? But I'll also tell you that in your practice that you see which ones are really great to start off is ortho relapse, because back in the day, we were told after their braces came off to wear their retainers for a little bit only at night, and then after 6 months, 8 months, they didn't need to wear them anymore, or they chose not to wear them. So ortho relapse are the wonderful ones to start off with. And I'm sure a lot of your team members would like to have aligners, and that's a really good thing so they can show the patients, I'm wearing my clear aligners, and they can tell them how nice it is.
We might
So
be
now
jumping ahead, Brenda, but we do have a question.
sure.
Somebody's asking if they don't have a scanner, can they send a model to the lab and they say TX plan, but I'm thinking RX plan.
No, they're probably saying like for their treatment plan.
Oh, okay.
So each aligner company has its own protocols. So you would have to find out from them. Like I do know like Invisalign, you can send a PVS, but they want you to have the PVS taken with their own Invisalign trays or Invisalign, yeah, impression trays. Other ones, you can use your own impression tray, but most of them are PVS and they scan it in to see. But and then there are some companies that do not take impressions yet. Yeah. But I'm sure that if you talk to the sales rep of one of those companies, maybe there's a workaround. That's what I would try. Any other
Thank you.
questions?
Yes. Somebody stating they don't have scans and are pre-op pictures enough.
No. You would still need to take an impression, a PVS impression to send in. Photos, they can't do AI, artificial intelligence, or they can't work a case to move these things digitally to a perfect outcome, if that makes sense. Because if you have photos, you can't really Photoshop those to see how a tooth would really move. So I know like different aligner companies require what photos they want, what impressions they want, what scans they want. Being clinical, I always love to give the lab more than what they may need. I really think panoramic x-rays are very important to send to an aligner company, because just because how a tooth may look like in the mouth, what is under the bone where you can't see it, right? So I find it very important to send a panoramic film along with your pre-op photos, your scan of upper and lower arches. Like I said, some aligner companies want, if you do not have a scanner, they want the upper and lower with a bite, so they know how that the teeth occlude right now. Any questions on that part?
I'm not seeing any. Thank you.
Okay, you're very welcome. So for your most successful outcome, you want really good records. I'm kind of a stickler on my records. Here's like my tray setup. I like to have my Columbia retractors, a mirror. Some people you can use buckle mirrors if you don't have the retractors. The retractors I like for my photos is, if you see in the photo, there's double end. One is a C shape and one's more like a Y. And you'll see when I'm taking it that the Y, the patient can pull it back and you can get that first molar bite relationship. So these are courtesy photos from Dr. Carrie Witten. And these are the photos that I like to take. I like to have, and whatever aligner company you're working for or with, they will have a template that will tell you what the minimum ones that they want. Like I said, I like to give more, because if they don't want to use it, then they're fine. But we know clinically, we hate having to bring a patient back, right? So it's like, get everything that you need, give it to them. If they don't want to use it, then they don't have to. So the images that I like to take is front smiling, and then front non-smiling. And I call it, it's like a repose. So you have the patient just breathe and then breathe out and put their lips together. Background is very important to me. I don't like a big shadow. In office that I worked at, I went to Joanne Fabric and got a dark navy blue felt that I would bring out, and I had like a little nail that I would just put on and then have my patients do their photo shoot there so they could model. And then you want the right side of their profile. I like to have the hair behind the ear. That way, the aligner company can see if it's more of a skeletal class case, if they are more protrusive. And then here's the buccal shot. And with that C part, I have that in the mouth. And then I have the patient bring it forward so it gets that buccal vestibule and corridor really well. And then when you are doing like the face shot, you get it to their shoulders and their head. You don't need any other part of their body or have it way out in the air or the ceiling of the operatory. And then here is where I turned it to the Y-shaped side and have the patient bring it back like almost like a bow. And you can see how you can see that molar relationship for the malocclusion. And then I do the same. I have them loosen it on the other side and then pull back on the other. And then I take it. And then here's an occlusal shot. That's where the Columbia retractors come. I have the patient hold it that way it pulls the lip out and have the mirror in. I press the mirror to their lower occlusion. I have the patient tip back and I take it standing behind the patient. I usually have the patient at waist level to do this. And I'll talk about mirrors. So with the mirror, I've seen people use a heating pad and put their mirror in the heating pad if you're only one person taking these records. That way the mirror doesn't get foggy. So you can have it under a heating pad so it's nice and warm so it doesn't fog up, or you can have a bowl full of hot water and then put it in and then hurry up and dry it off and then place it in the mouth. Or you will see on this one, Dr. Whitman, they had a little fan on their mirror. And so I was very interested in that. So I looked it up, and Amazon has this fog-free dental occlusion photography kit. So, or you could also ask, whatever your dental supply company is, if they have them. And then for the lower, I then have the patient hold it with their arms down, lips out, and then I rest the mirror to the occlusion flat on there, and then I have the patient then hold their head so I can get that nice shot. Any questions on the photos? And then I'll show you like how we had our wonderful patient here.
Yes, Brenda, we have
Yes.
questions in relation to the mirror.
Yes.
They're asking if you like to use the mirror for the right and left posterior pictures. Why or why not?
Okay, so you can use the buckle mirrors that you're talking about that almost looks like a teardrop. When you are uploading those to the template, make sure that the aligner company knows that that is the right side or the left side, because it will switch because it's a mirror, right? Has that ever happened to anybody out there where they accidentally put it in the right side of a template if you were doing any of your aligners? Or not even that, if you're putting it in your patient's chart? I know that happened to me once upon a time. I made that mistake one time. So yeah, you can, buckle mirrors work wonderfully if you didn't want to have a retractor like this. And you can get these retractors too from your dental supply company. They even come in black now. Amazon has packets of those too that are, and I don't know what their brand name is. I just always look up like dental photo retractors. Any questions about any of that?
Not
So,
about that part, but we do have one I missed, so I apologize, attendee who
fine.
submitted it. It's, do you need a cephalometric radiograph?
You don't have to, but if you do have one, send it. That falls under everything that I said about send more. If they don't want to use it, they don't have to. But that helps to verify if it is definitely a skeletal case, correct? So you would know if it is a more complex case that may take longer, and you would want to steer clear of that until you have mastered clear aligner therapy. So we're going to go on here. So as you see, we're setting the patient up so you can have that anterior shot. I know that I also usually like to get one more photo. Instead of having them closed all the way, I will have them open slightly, especially if they have a lot of that chipping of the incisal angles or that wear. Even though that a lot of that will show up on your scan, I still like to have it. Because like I said, more is better, cover your butt. So here is the positioning, like I said, and there's that mirror that has a fan on it. It was like I wish I had that years ago instead of having to put hot water or put it under a heating pad. So right here, we're taking the shot of the mandibular arch. And on the other one, we're doing for the maxilla. And now we're going to talk about any more on photography before I start going into the scans. Anybody have any issues with sometimes capturing further back?
We do have a question in
homes.
regards to it says they mentioned several companies, Invisalign, Shirt Smile, and a few others allow you to use screenshot JPEGs of the scan in place of intraoral photos. Does that work with NDX as well?
They really, I think they require 3 different photos. The smile, and they don't require like the mirror shots. But I really think it's important for any aligner company to see an actual patient's face. But that's just me. Because, with a scan, if they don't see where their nose and their chin is, I, don't know how, if they have problems with a midline, especially if the patient's midline is off, like 0.5 millimeters or what have you. But, that's like I said, like I am going to go over like different aligner companies because Dr. Whitman, she's using NDX aligners, but there's also, Candid, Sure Smile, Invisalign, Clear Correct, so many out there. The best thing is to do is ask your sales rep for any of those companies what they really require. But like I said, me personally, clinically, I give them all the information because none of my patients are just teeth, right? They have a face. Does that make sense? Any questions on that? And now we're going to talk about capturing intraoral scans. For aligners, it's very important to get distal of that terminal molar. Characteristics of eligible scans is no holes. You have at least 2 millimeters of tissue around each tooth captured, and you want that overhead light, dental light off. You don't want your loop lights on. You want to make sure that you have captured the incisal edges and make sure there's not a dark line around it. If you see this dark line or ashy look to your scan, that means you have it not captured all the way. There's a space. So it's really 2 rows of teeth. Like it has the buccal separated from the lingual. So you want to make sure that you don't have that dark edge. So that way you know that that tooth is nice and flat in there. And even if you're doing, because you can correct one arch, you can do a single arch case. Like patient has beautiful, nice straight lowers, couple rotations on their upper. We can treat one arch cases, but you still need upper, lower scan and the bite. And then when you're exporting the scans, you want to make sure that upper and lower STL files can close onto each other to simulate their occlusion. And you want to make sure the teeth are dry and clean of debris, especially our teenagers, right? That come in after school and mom gave them a granola bar. Give them a toothbrush. Get those teeth brushed before you start doing your records. And make sure the patient swallows, air flosses, and then start scanning. I like to use not only air floss with them, I'll have my gauze and I do a gauze sweep so I don't have little tiny bubbles in the pit and fissures. So here's some examples of bad scans, and these are things that, yes, we do get in. In the top left, as you see on the lingual, not enough data captured on those molars on the lingual. And then we're going to go to the next one to the right. You don't have the terminal molars. You really need to. And then if you look between number 10 and 11, there's an artifact there. And then we're going to go to the lower left. That is a double image. And same thing on the lower right, double image. There's holes on the molars. And then here's another bad example. A lot of holes in that scan. As you see, don't have the terminal molars all the way. Just too many holes. Too many holes on that one too. Same thing, if you don't have that distal of that terminal molar, the aligner will not be able to fit and move the teeth how it needs to do. And this is the ideal scan. My typodont had lost a buccal restoration. You would want that filled before you scan. And this will just show that you have proper bite. And whatever scanner that you use, there are some that, even though it comes together, does not mean that your occlusion is right. Just because you might, with another brand, just because you get a check mark, doesn't mean the occlusion is right. So always check when the patient bites down, what your bite looks like on the screen is the same as that patient has in their mouth. Okay, this is not quite an ideal scan. Everything is, but if you see the little black, it's the reflection of this typodont. But on real teeth anatomy, if there was a black line that ran and it kind of looks a little bit scratched, that means there is not enough data. And then I would just go ahead and scan that area again, and that would fill in and make it all tooth colored. So here it shows that you have the distal of the upper terminal molars. So any questions on the scanning part and what needs to be captured?
We do have one that came in regards to the clinician is asking if a patient wants aligners and they do not have a treatment plan, such as fillings and crowns, that they need to get done. Do you prefer for the doctor to do the necessary treatment before starting the process for aligners, or could they do the fillings and crowns while the patient is in the process of getting aligners? And will that affect the aligners when it comes to the impression scan?
Yes, a very great question. Thank you so much for asking that. You want all decay taken care of. So if you are doing composites or what have you, If you're going to do for a crown, unless you're trying to put it in a different alignment or maybe close a space for tooth discrepancy, like if there's a patient that has peg laterals, you would want to wait until they're done with their treatment to treat peg lateral teeth. I know that a lot of aligner companies will put an ideal tooth shape in there so you can fill it with either a composite or a temporary material. So at least the patient, as these teeth are moving, you don't see this peg laterals in the aligners, if that makes sense. And the same thing, if a patient lost a tooth and you're setting the case up for an implant, the same thing, they can put, as the aligners move the teeth and create a larger space, they can put a tooth shape in that area so you can put a composite so the patient, especially on the anterior, so it's not like they're going around with a missing front tooth. Did that answer the question for the restorative part of it, like for cavities and crowns?
I believe so. I'm trying to see the timing of something else
You
that
can just
came
do a
in.
thumbs up or something, whoever's out there that asked that question. Did I
Yeah. Well,
did I answer that one
oh,
correctly
they
for
just
you?
typed in yes.
Okay. Yeah.
So,
So,
you're good to go.
but like I said, if it's like a molar, you could even stabilize it with a core, build up until that, but to do restorations, especially major ones, like if it's like a MODB, your aligner is not going to fit that tooth that you already have made. So then you might have to go in and do almost like a mid-course rescan to do that. And you would have to check with whatever aligner company that you're working with, what the extra fee was. Because let's say if they're on aligner number 7 and it was 7 out of 20, you still have 7 from 20, all those will not fit with the case that you scanned for before restorative. So I guess I'll just put it that way. So now we're going to talk about our case submission. On every aligner will have their own RX information put in. Things that are important. Now, if you are a doctor that's in a large practice and there's more than one of you, you want to put your name as the contact person, and even if you wanted to put your cell phone number. So whatever doctor that might be working on your case or technician, if they're doing it through AI, they know how to contact you. But you need the patient's full name, patient's date of birth, and it's really important to verbalize the patient's chief complaint, not only for the aligner company, but then you in your own records. So, the reason why, Sally Jones wanted aligners because she does not like the way number 7 and 10 are rotated and they flare out. She has an anterior tooth that is in crossbite, whatever it is, or even like I said, that they have a little bit of crowding now, that they once had orthodontics, like they had they were in ortho for 2 years. That's good for the aligner company to know. And I even, like, if they even said that once upon a time, like go back to my age, time that they may have had headgear and they were in ortho for 4 years, that stuff is really important. Additional notes like on the case that I have, the patient that shows that she has a missing area, doctor not only is for her malocclusion, but we're opening more space for her implants. So you want to let them know which teeth have existing crowns, because you might not want an attachment placed on that crown. So you want to provide as much background as you can on the case, and your treatment preference. Either, like, a lot of people do not like to do IPR. I think it's best to always put little to no IPR. So that's interproximal reduction, and see how the treatment plan comes out, and then they can adjust it for what may need to be, depending on the shape of the teeth, right? Some people on their anterior, they have the black triangle, and that's a good thing to put on the chief complaint if they're concerned about food trapping and their black triangles. They may need a little bit more IPR. That way, when they bring them in, it closes that black triangle. I really don't want to go into like bite ramps, elastics for like class 2 elastics quite yet, because if you're starting, like I said, I would like you to do more of your mild to slight moderate, keep it on that smaller scale. Because I want you to love this. I want you to see great results quickly and see how your patients are going to be so happy and be in love with you, and then they'll send everybody else to you. But like I said, each aligner company has its own requirements. Same thing I said, more information you provide to them, the more information that you keep in your records, because patients do forget how they started off, right? And, same thing with any restorative. Some will say, my teeth looked better before you did those crowns. And it's like, no, you were in love with them. Same thing happens sometimes with ortho. And like I said, like with aligners and moving teeth, they forget where they started. Any questions on that part? Okay, so
I don't
once
think
you
I've seen
have,
any. Oh, I do see one. Some
okay,
companies don't require pictures, just the scans. Why the pictures are needed, or maybe why are the pictures needed?
and I think I did answer, somebody had a question similar to that, because the patient has a face, right? Where, if they have a photo of the patient's face, if the patient, I hate to say it, if their nose is off-centered, and if they're trying to follow just the upper and lower arch, and they set that midline, it may not look right on that patient. It may be off. You want more of an aesthetic, pleasing outcome, right? So, I really, clinically, I don't understand how, I mean, that's fine with whatever aligner companies say that they don't need any photos, but it's a person, it's just not dentition. So that's why I say I always give them more. If they don't want to use it, then that's up to them. But I think it's very important. And not only is it, I think it's important for the aligner company who's producing these for you. It's important to have for you as a dentist, just in case, right? I forgot what that saying is. What is it? COB, cover your butt, or CYB, cover your butt. Because if it is somebody that has that malformation in their face and it looks off, then and I think it's important, because how can they tell, like with the smile line, where their lip line is? You can't see any of that just on a scan. And I think that's really important to have a successful case for your patient. That's just, you know, but if that's what your aligner company tells you, and I just personally, and I know like the dentists that the ones I have worked with for aligners was the same thing, you know, same way. And does that answer the question? So now we're going to talk about, so there's different ways to export scans, especially like if you're using iTero, it's very easy to submit to Invisalign, right? You're done. But if you want to use a different aligner company, here are steps that you can export your scan data with an iTero to whatever aligner company that you would like. And this is going to, well, thank you. Step one, you're going to go to, when you're going to take the scan, you're going to go to iRecord. You're going to take the scan, but in your RX, when you're setting it up, you're also going to choose myitero.com. And then you're going to scan your patient. You're going to log on to, because it's going to upload automatically to myitero. Then you're going to log in, click on your patient, search for your patient. And when you're clicking on for your patient, make sure that you're clicking on the iRecord and then before clicking onto the export. The export window will come up as you see on the screen there. Then it's important to ensure you follow these steps. You're going to want to export type is open shell. And you want to make sure your files are oriented into an occlusion on your data format. And on your file type, you're going to put STL, no color. And then you're going to have another box where the files will appear in downloads folder, ortho-CAD _ export _ patient's ID. And Jessica, are our attendees getting all these steps to them, or should they take a screenshot of this?
Do you have this in a PDF to send over and share?
I do not. I think Eduardo does.
Okay, maybe connect with him after the webinar to request it and send it my way, and I'll be more than happy to email it out.
Okay, perfect, because I know I don't want them to have to, you know, get out their phones and start taking pictures, unless you want me to strike a pose. Okay, so patient's ID number. If all the files are zipped, double click on the zip file, click to extract all, choose the location where you want the files out of the zip to be stored, and click extract. And now the scans are ready to use. And then on your desktop, when you put all your patients' photos and if they have a Ceph or a Panorex, then when you open up your aligners portal, then you can then upload all that information. So that's for iTero. Now we're going to do how to export the scan data from 3Shape.
I'm sorry, Brenda, can we go back to iTero really quick? Somebody's
Sure.
asking if exporting is necessary if they're submitting for NDX aligners.
Yes, so they need to do this. With iTero, the only way that any aligner company is going to get this information of your scans is if you export it this way. Because it does not allow you to our lab. It's not like the crown. If you had a lab selected that you can select, you have to do this way. That way you can export your scans and then upload your patients, like I said, photos and panoramic, if that makes sense. I'm hoping one day that all the scanner companies will allow, to have it more of an open library for different labs and different aligner companies. Any questions on the iTero part? Any other ones?
Not seeing any.
Okay, so exporting from 3Shape, you're going to go there's two different ways to do it. You can go to from case view, go to cases, select the order that you want to export. But prior to scanning, you just scan the regular way of scan only from that part, if that makes sense, that you don't have to do like iRecords. And then, so once you get everything scanned, then you would go to your cases, select the order, export DCM/STL-PLY format. And then you'll open, there's 3 dots. You open that up, select export, then scan. And then from the patient's view, after it's been scanned, you can do it from that page also. Find the correct patient, select it. There's 3 dots. And so it has the steps. Step 1 is the patient. Step 2 is the status scan. 3 is the 3 dots, and that will drop down and give you 2 choices, and you want the scan. And then once you hit the scan, another box will open up, and that's where you'll hit export. So to me, because I've been used to 3Shape a lot longer, to me, this is an easier workflow. Any questions on how to export the scan data from 3Shape?
Not seeing any.
And if you ever needed to make a copy of your scan, those 3 dots you can copy also in an area if you wanted to duplicate to send it again if somehow it got lost somewhere. And because sometimes those scans get, when you go send, who knows where they go after they're somewhere floating in the air. But how to export more from the 3Shape. And then once you find it for your DCM, then you save as type selection, click on it, switch to .stl/PLY or .ply . And like I said, then on here, you would also have your patient folder with their name. So when you do, then go to the portal of whatever aligner company that you're going with, and then you can not only export your data here, and then you can just pull the patient's photos and scans, or photos and x-rays, whatever type you have taken. Prime scan, you scan the patient, and then instead of going to connect or anything, then you're just going to go to the model tab. And then you're going to click on the DS logo, and then the screen will drop down. We all know where that is because that's where you're doing your calibration, right? And then you're going to export from there. And then a folder will come and you select the STL files. Highest resolution is what you really need. So in the Dropbox, STL file, highest resolution, click export. And then we have the meta. So these are, I'm doing like the main, most popular scanners that we see out there. But there are so many different scanners out there this day and age. So most of them have a fairly easy export walkthrough. And if not, then you can contact whoever was the supplier and ask them how to export that scan. So with Meta, you would go to the workbox, select the cases you wish to export. Then you're going to go to the work file list, an export window will pop up and it will have your exporting preferences. Select exocad, just as it has right here. And then your mesh format, you're going to want STL, and image format, convert to JPEG, and combined individual mesh. Boom, export. But you want to make sure that those occlusions, the file format is in there too. So any questions on that part of exporting? I know that it's very intimidating to begin with, but you'll get it done. So once you submit your case for your treatment plan, all clear aligners, like companies, have that doctor portal, like I said, so you can submit and manage cases, submit your records and treatment plans, like if you are going to set this case up for restorative, for veneers, crowns, whatever, implants. So what happens is once it's submitted, either some companies do the AI for the artificial intelligence, and then there are real designers that create the case. Some aligner companies, then you'll get a notification saying that your treatment plan is completed, and then you can open it up and view it. Some aligner companies will allow you as the doctor to tweak or say, yeah, I don't want an attachment on that said tooth. It'll let you place them which tooth you want. There are other ones that will not let you change it yourself, but you can then write to them, yeah, I don't like the attachment there. I do not like the outcome. That's a little bit more protrusive on number 8 and 9 than I would like. Or if you look at the upper, you'd want it more. To me, it looks more like there's an open bite. So you would say to them, okay, I want 8 and 9 retruded a little bit and brought down a little bit. Does that part make sense? So you can, just because the aligner company says this is what you're going to get, is not necessarily what you're going to get. You can change it. Make sense? On that, any questions for that part?
None right now.
Okay, so let's say, okay, everything looks beautiful. I love that treatment plan. Go ahead and send me my aligners. So now we're gonna do case delivery, and doctor is using our NDX aligners, but like I said, you have Candid, you have Invisalign, you have ClearCorrect, Sure Smile, and all the other ones that are out there now too. Before, like as an assistant, when I would get the box, I would open it up, make sure there's the correct number of trays in the box that are on the treatment plan. You will get, most aligner companies will show you which teeth need the IPR, like IPR or your attachments. And then before my patient comes in that day, I have my armamentarium tray setup needed, the instruments that I need. But it's very important that you place your attachments before you do your IPR. And the reason is when you're performing the interproximal reduction, and that's something only a doctor could perform, we assistants or hygienists cannot do that. It is removing actual tooth structure. I like to tell the patients, if they do need it, that It's going to feel odd because it is like sandpaper disc, right? I tell them that we're slenderizing the tooth a little bit and polishing it. That way they don't freak out when you say, yeah, I have to remove, 0.1 of number between 24 and 25. It's like, oh no, you're going to be taking some of my tooth structure off. But another reason why I like to look to see how many attachments I'm going to have, that way I know how long of an appointment I'm going to need. Because we don't want to get running behind on a patient because our next patient because I thought we were only going to do 3 attachments and in reality we have 10. So things that you want to do, you want to have your disc for your interproximal reduction. You want to have your etch, you want to have your bond. You can use packable or flowable for placing your attachments. You want your dry angles, cotton rolls. Have more than you need of all this stuff because once you start retracting a patient to dry them, that's when the floodwaters start. You want to make sure you have your etch and you want a retractor to keep everything, the lips out of the way. And doctor is using the Optigate by Ellaclear, but there's Comfort View. It's a lip, then it's by Premier. There's also disposable retractors by Luminite Plus. There's Spandex Advance by Hager. So, you can ask your sales rep, like from Patterson, Shine, whoever you use, for what lip retractor for placing or bonding brackets would work best for you. So for teeth that are not crowned, you would want to use 30 to 50%. I think 50% is a little bit high. Most of your etching gels or liquid, I like to stay around like 35% phosphoric acid. And like on my tray, I would have more of my micro brushes in case there gets some saliva contamination. And then you're going to want to have your template and aligner number 1 out. So then the patient will come in and I usually I rinse them off. I try my template in. I try aligner number 1 in to make sure they both fit. Take my number 1 and move it aside off of my bracket table so I don't accidentally fill my aligner number 1 up with composite. And I just have my template there. Okay, so now we're going to talk about your interproximal reduction. There are so many, you can get strips, you can get the disc that is more convenient and more comfortable for your fingers. And then you can get a gauge. I like to have the gauge because if it says we're going to do 0.07, then you can use that gauge to see what they are right now. Because there are times that you think you might have to do interproximal reduction, and in reality, they have enough space. So you don't want to over remove tooth structure. But these gauges, they go by the number and as the disc, like the lighter colors are usually the finer ones. And my doctor will usually start with the finer one, even if there's more, and then go to the rough one and then go back and smooth and polish with the finer one. And if you do any type of IPR, a lot of times for patient comfort, because some patients are more comfortable, more sensitive It's like you can barely do a little bit of enamelplasty and they come in, they say, I can't even breathe, that my tooth is so sensitive. So after we get done doing the attachments, performing the IPR, then I will do fluoride, and then that way it calms that tooth down. So now we're gonna start a video here. Are there any questions before I get into like Dr. Witten? She's going to be placing the attachments, and I will be pausing this along the way to go over steps. But before I get to that part, is there anything that anybody has of questions?
There is one. Does an NDX orthodontist actually create the treatment plan or CLIN check like the website says? And should I
Yeah.
expect to alter the treatment plan like we often have to do with the CLIN checks made by Invisalign software and text because the program movements aren't actually possible?
Right. Yeah, so that's you probably will not have as many of a correction like on your treatment plan outcome. Does that make sense? Because it is an actual person. And like I said, they have the photos. Does that make sense there to you? Because when
It
you have
does to me. We'll just wait for their feedback. We've got another
okay.
question. What type of fluoride, rinse, or gel in a tray?
Oh no, I usually do my brush on fluoride and then put the tray in after it dries on their teeth. You can do that, or you could even use send the patient home with a little bit of MI paste and they can just put it in the tray, a little layer of it.
Thank you. And we're not seeing any other feedback.
Okay. I'm going to play this video and we're going to go. So I'm going to pause it here.
Oh,
So
the
here,
person did come back and say the website says NDX orthodontist, so I expect their treatment plan to be better than mine as a general dentist.
yes, exactly. Because they're orthodontist, right? They went to school, they should know, like, yes,
They
um,
specialize in the area.
yes, I mean, that's what they do, odontology. I'm trying to explain this part too. However, if there's something that you want to move, it should be pretty spot on, because they are orthodontists. But the sheet that I was telling you that most of aligner companies will send is right there. I like to have it out, so I know exactly where my attachments are. Before you begin your etching process, and like I said, I like to try the trays in. I will dry my template off, but when I have it in the patient's mouth, I am aware of where all those attachments are going to be. You do not want to etch the whole tooth. You just want to etch where the attachments are going, because if you etch the whole tooth, you're going to get bonding, you're going to get the composite all over, and you're going to end up having to remove all that. And if you don't remove all of that, you have just caused another layer of your tooth. So when your aligners go in, it can change the outcome of your treatment because you're putting more lingual pressure on those teeth. Does that make sense for that part? I just really want to make that clear on that. How important it's not that you do not etch the whole tooth. I usually will have my tray loaded and ready to go. Depending on how many attachments, I usually do 1 quadrant at a time. So here I am, I'm in Michigan, I'm our RDA, so I can do this, place the attachments. So I only like to do one side at a time because I only have 2 hands. I keep trying to grow those extra 2 arms and hands, but I haven't been able to yet. But isolation is so important because if you have any saliva or fluid that has contaminated it, those attachments will pop off. So I will usually load my tray on one side of my template, then I will put it in a box. You can find like dental resin shading boxes. If you had an ortho box, you can put it in something that blocks the light so it doesn't cure while you're etching and placing the bond. And you can add attachments to a crown, but you're going to have to use your porcelain etch. So we're going to play this a little bit here. So right here, she's trying in her aligners without any attachments. And he's checking the fit of to make sure it seats all the way. He is loading up the composite. I'm gonna pause this right here. Okay, so if you're using a flowable, you want to make sure that you keep the tip in your attachment area when you're expressing that out. And you are going to want, you don't want to overfill it, you don't want to underfill it. Think of it as you're putting water in a glass, and right before it starts to overflow, so you have that little slight bubble, that's how you want your flowable. For your packable, you want to make sure that you have it packed in there really nicely, and you don't want it overfilled because you're going to have a lot that has expressed out, and that takes more time to clean up. So he's packing it in. And, you know, whatever kind of instrument that you want to use. So since it's the assistant and the doctor, they're going to fill all the attachments and do this in one suite. As I said, that's not my preferred method. I like to have more control. And I know that, like most of my patients, like I said, you retract them and dry, then all that saliva goes everywhere. So now he's loading that. And, you know, sometimes on those second molars that have attachments, we know those salivary glands really go crazy, right? So after you place your material and have it, doctor is going to be using Conceptus by Ultradent to clean, do a pre-clean. I usually use fine pumice without fluoride. So this is another option, I guess. The Conceptus has little glass beads, and if you smear it, it takes off. It has like a chlorhexidine in it too, so an antibacterial and a cleaner of the plaque. If you don't do any type of plaque removal, you will not be able to etch the tooth properly, and those attachments will come off. So she's done the cleaner, rinsing, drying, and now she's gonna, after this step, after everything's nice and dry, you'll see that she'll etch the tooth where those attachments are placed. And me, I don't like to do more than 4 attachments at a time. And that's my personal preference, but I'm usually doing it by myself. But you'll see where after she gets done rinsing, and then of course you want your bonding agent. You want to make sure you follow manufacturer's directions, even on your etch. If it says have it on for 30, 40 seconds, have it on 30, 40 seconds. It should be nice and frosted. If you don't have that frosted look, you're going to have to re-etch that tooth, because sometimes enamel will etch differently on tooth to tooth. So I think you'll be able to see that, how frosted it is in the areas that she placed it. When you use your bonding agent, you want to have a nice thin layer, so you want to make sure it's nice and air thin. Make sure that you spray, just like if you're placing a composite, right? Make sure that you take all the water out of the syringe tip before you put it on the case. So now, well, she's going to seat the template, having the patient bite down to make sure it's totally engaged. And here is where I usually will have the patient open up, and I'm holding it, and around the attachments, I push back the extra material away from, if they have overflow, away from it. That way I can pop it off with a scaler, or take a little pointed enhance or shofu point. There's many different points. Some you will even use like a greenie, and go around to get all the excess material off. So right here, she's gonna push the material away and make sure that it's engaged. While I like to hold the template and press it against the tooth, because templates are very flexible, and I want to engage because I want to make sure that my attachments are there. So I am holding an instrument as I'm doing my light cure. So right now that I'm doing one side to the other, and as you see, that cotton roll is pretty saturated there, and you'll see what happens when the template comes out. And you'll see that the attachment stays inside the template because saliva got into that area. So then they had to re-etch and bond. So I'm going to pause this while I'm going to keep doing that. And then if you guys have any questions, you can ask, because we all know how to light cure. But me, like I said, I would be pressing that template down. You're going to, like kind of work the template off to get it off of those attachments. And you'll see here, I don't know if it shows it. Trying to see if you can see it. Do you see the attachment was in the aligner still? So it came debonded on number 14. So different aligner companies, on your template, they'll say that you can cut. So Dr. Witten, she usually cuts hers in half, and you'll see on the lower when we get to that point. But I'm going to have you look at the different shapes of the attachments. Attachments sometimes can be sharp, right? But they're the shape and they're sharp for a reason. They're that way to engage in the aligner. So don't polish those sharp edges off. It's really going to be more comfortable to the patient to have their aligners in, so they will have more compliance. And that's so here, the 37% etch. That one's by Visco. There's Etch Right. Ultradent has their etch. So now the same process. It gets tricky. We know trying to dry that tongue gets really in the way. So that's why I said always have more cotton rolls than you think you need. That way I have to find more. And then you'll see where when they place this, she's doing one side at a time. But I want you to see where the teeth have been etched. You have that nice frosted area on the tooth. Now she's applying her bonding agent. And after I take my templates off, I make sure that I'm removing all the flash, but I'm also flossing in between all the teeth because we know what happens when you air thin bonding and then light cure, right? Those teeth get bonded together sometimes. And right here, you'll see where she's doing one side, but each aligner company has its own protocols. Check with whatever aligner company you do are using to see. But I will usually engage so as she's pushing all that extra material away from the attachment area. And then they'll cure those. And then she'll take that off. And then he will cure a little bit more.
Brenda, this just popped into my head about
Yes.
how many cases with you going through the templates, the attachments, following front to back, do you feel it took you before you became proficient?
Placing attachments.
Yes.
Okay, it depends on how many attachments you have. Because isolation is a big thing. And like I said, I do one side at a time. So if you're doing 4, you're loading your tray up already. The teeth are pumiced already. So if you have a 30-second etch, so if you have 4, you don't count when you first started your etching your first tooth. If you're doing 4, it's after you etched your 4th tooth, then you count your 30 seconds or 45 seconds, however many. Then you're going to do the rinse, dry, depending on how much saliva they have. It's not as long as you think it is. I mean, this is a 16-minute video, but it's more when you're doing more than the attachments here, right? And then light cure, depending on what curing light you have, it's 10 seconds per. If you did not put too much material in your aligner or in your template, then you're going to have very little flash around that tooth. So I would say, like my delivery of my aligner cases that I did, I used to allow, well, depending on how many attachments I had, some I would allow 20-minute block, some 30-minute block. Most of it was 30. And if I had enough time, then I would do patient education. Like I like to show, and sometimes I'll even make a copy of where their attachments are and give it to them. But I like to show the patient where their attachments are. And so if for some reason one comes off, they can call us, right? So we can place the attachment back on.
Thank you. And then we have a question. Can a saliva ejector be used to help things dry?
Most definitely. And I guess there are other products out there, too, that doctors are using. There's like a Mr. Thirsty, there's Isolite. You can use that too. But yeah, there's a lot of saliva here. I mean, they were going through cotton rolls. I mean, this is like my typical patient. Like you just look at them and their saliva squirting out of their mouth. But yeah, saliva ejectors with retractors. Well, right now she's using on a high speed to clean up the flash. Like I said, with me being, I can use a slow speed with a polishing point to clean all those off. But if you overfilled your tray and put too much bonding on your tooth, etched your tooth too much, you're going to be pretty much using, 7901 to clean it off. You're going to be using fine diamonds to clean it off. So if you don't overload your tray, then you're going to have very little flash. This step goes so much faster, if it makes sense to everybody out there. But like I said, as you see, most attachments are sharp. If it's too sharp, then let me stop this for 1 second. If you have an area that's too sharp, I don't want a patient's lip to be cut either. Barely smooth it, but I know it's going to feel awkward to them. They're not used to having anything on it. And just like any of you out there that had ortho, or have had friends that had ortho, how they would say my lips all cut up and they would have a little box of wax to put on. You can always give the patient ortho wax that they can put on so they can, when they don't have their aligner in to begin with, so they can, not too hot of soup or else they'll be a waxy mess, but to be able to eat until they can build up the tolerance of the change of those into their mouth. But like I said, the ones that I have said, even the patient here, she said, oh, these are more comfortable. I like it better in. And I know Dr. Whitman, instead of like on her delivery date, they don't place attachments. They send their patient with aligner 1. So the patient gets used to taking it in and out and gets used to wearing that aligner 1. So she wore it for a week, then they brought her back and then placed the attachments. So that's more like for patient comfort. So here's the ones that I talked about for the IPR that have the little parts for your finger. I think you have better control than you do the strips. If you're using the strips, make sure your assistant's holding that up, because I've seen many times where that lip has fallen down and wasn't a pretty sight. So we're gonna
So
go
somebody
go.
commented that to do the lowers first because saliva will increase.
Yes. Yeah, I usually do the lower first myself because I think it's a patient thing. I don't know why. Maybe on the upper, their salivary glands, their brain mechanism keeps thinking, oh, more stuff in my mouth. So that saliva just wants to flow like crazy.
And somebody also commented before I asked the question that that's a great idea. Place attachments a week later. I'll do that. Thank you.
Yes. And I love that idea also. It's like, then they get used to taking it in and out. And for those of us that have seen people or have had aligners ourselves, know that when it's new, right? And then if you have the attachments on it, it's even harder to take off. But there are little tools too that you can get that look like, I think they're Audi tools. There's different names to different tools they have. Kind of reminds me of like a crochet hook that they can use to get back there and kind of pry them off to begin with, and then so they get used to it. And same thing to engage their aligners after you have placed the attachments on, chewies. And if you don't have chewies, you can always give the patient some cotton rolls, or I even cut off a saliva ejector in little pieces so they could take that home to engage their aligners also. So he didn't have a gauge, but first of all, you want to floss to make sure if there is resistance, then you know that those are the areas that need IPR. And start off with the finer diamond disc and work your way if needed. And this one has a single edge, I mean, single-sided. You can get these in double-sided. Teeth don't grow back, hair does. So I say start off slow, and that's why I would not suggest a double-sided. I have seen too much IPR done before, and that's not a great outcome, right? Because teeth are supposed to be nice and curved instead of, I know that they say that you can put a disc on a slow speed to do your IPR. You don't have as much control of it, and it usually will do flat. So then if you're doing anterior teeth, if you have that flat round disc on your slow speed, your teeth are going to look like this. So you're going to have a nice deck when you're done, if you're doing IPR and all the anteriors that way, instead of having the control where you can make sure you maintain the shape of the teeth. And so that, as you see, that sometimes getting into those areas with the with the disc can be a little bit difficult. But this is the reason why you want to do your IPR after you place your attachments, because on some people, you just look at their gum tissue, what happens? And trying to get that hemo under control to do your etch and your bonding, you're going to make it too hard on yourself. We're trying to work smarter and easier, right? When we're dealing with saliva, it's hard enough. So sometimes, like, patient has that area that was missing tooth, that side is easier to go down. So I like to show my patient which path of insertion is easier to get it on and to take it off. And then, your instructions, I like to give a goodie bag. And he's explaining that, okay, we're going to do this for, a week. And then, so thank you so much. I would like to answer any questions everybody has.